Welcome to today's lecture on bleeding. In this lesson, we will explore the different types of bleeding, their impact on the body, and the essential emergency care techniques used to manage and control hemorrhage. Understanding how to assess and treat bleeding effectively is a crucial skill for every EMT. Let's get started. Perfusion is the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. This process ensures that cells receive essential substances while eliminating waste. Proper perfusion is vital for survival. The speed of blood flow must be carefully balanced. It needs to be fast enough to maintain circulation, but slow enough to allow cells to exchange oxygen and nutrients. While some tissues require a constant blood supply, others can survive with less. All organs rely on adequate perfusion to function properly. If an organ system fails due to poor perfusion, the entire body is at risk. In emergency care, our goal is to support perfusion until the patient reaches the hospital. The heart, in particular, needs a continuous blood supply. Hemorrhage is the medical term for bleeding. When this occurs externally, it is visible. Prompt intervention is crucial to prevent excessive blood loss and potential shock. Estimating blood loss can be challenging because blood appears different on various surfaces. However, the body cannot tolerate losing more than 20% of its total blood volume before serious complications arise. Significant blood loss triggers changes in vital signs. The heart rate increases, breathing becomes rapid, and blood pressure drops. These are key indicators of a worsening condition. The speed of bleeding influences how well a person compensates. While an adult can safely donate 500 milliliters of blood over 15 to 20 minutes, losing that amount rapidly can cause hypovolemic shock. Age and overall health also impact a person's ability to cope with blood loss. Certain conditions make external bleeding particularly serious. These include significant mechanisms of injury, poor general appearance, signs of shock, rapid blood loss, and bleeding that cannot be controlled. Bleeding can originate from arteries, veins, or capillaries. Arterial bleeding is bright red and spurts in sync with the pulse, making it difficult to control. Venous bleeding is dark red and flows steadily, while capillary bleeding oozes slowly. Each type of bleeding has distinct characteristics. Arterial bleeding is bright red and spurts forcefully. Venous bleeding is darker and flows steadily. Capillary bleeding, although slow, can still lead to complications if not managed. Bleeding typically stops within 10 minutes due to clot formation. When a blood vessel is injured, it constricts, slowing the flow, and a clot forms to seal the wound. However, if clotting does not occur, the bleeding will continue. Hemophilia is a condition where the body lacks essential clotting factors, causing uncontrolled bleeding. Even minor injuries can be life-threatening. These patients require immediate transport to the hospital. Internal bleeding is dangerous because it is not immediately visible. It often results from trauma to internal organs and can lead to hypovolemic shock if not identified and treated promptly. Several conditions can cause internal bleeding, such as stomach ulcers, lacerated livers, ruptured spleens, and broken bones. Recognizing the signs is crucial for early intervention. A high-energy mechanism of injury should raise suspicion for internal bleeding. This includes blunt or penetrating trauma, both of which can cause significant unseen damage. When assessing trauma patients, use the DCAPQLS mnemonic: deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. These signs indicate potential internal injuries. Not all internal bleeding is caused by trauma. Conditions like bleeding ulcers, colon hemorrhages, ruptured ectopic pregnancies, and aneurysms can lead to significant blood loss. The most common sign of internal bleeding is pain. Other indicators include swelling, distension, difficulty breathing, a rapid heart rate, bruising, and hematomas. Bleeding from body openings, vomiting blood, black stools, bruising over the chest or abdomen, and broken ribs can all suggest internal hemorrhage. Careful assessment is needed. Hypoperfusion, or shock, is a key concern. Symptoms include altered mental status, weakness, dizziness, pale skin, and increased heart rate. Later signs of hypoperfusion include rapid breathing, weak pulses, slow capillary refill, decreasing blood pressure, and changes in consciousness. Immediate intervention is critical. Scene safety is always the first priority. Be aware of potential hazards, especially in violent incidents, and ensure police presence if necessary. Follow standard precautions to protect yourself. Identify the mechanism of injury or nature of illness early. Consider spinal immobilization and any additional resources needed for patient care. Forming a general impression is key. Quickly determine the patient's overall condition, noting signs of trauma, age, gender, and potential life threats. Conduct a rapid exam to identify life-threatening conditions. If severe external bleeding is present, address it immediately before moving on to airway and breathing assessment. Circulation assessment includes checking pulse quality, skin condition, and capillary refill. If bleeding is present, apply control measures and prepare for shock management. Evaluating XABCs, exsanguination, airway, breathing, and circulation, guides transport decisions. Signs like weak pulse, clammy skin, or low blood pressure indicate the need for rapid transport. Patients showing signs of shock require immediate transport. Tachycardia, tachypnea, hypotension, and altered mental status suggest serious blood loss and a declining condition. Gathering a thorough history is critical in assessing a bleeding patient. Investigate the chief complaint by asking about any recent injuries, signs of internal bleeding, or underlying medical conditions. Consider both the mechanism of injury and the nature of illness when evaluating the patient. Use the sample history method to gather important details: signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading to the injury. Also, ask about blood-thinning medications, as they can significantly impact bleeding. If the patient is unresponsive, check for medical alert tags or ask bystanders for more information. Perform a detailed head-to-toe assessment, looking for DCAPPTLS, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Record vital signs and use monitoring devices as needed. However, in critically injured patients with short transport times, there may not be enough time for a full secondary assessment. Reassess the patient frequently, especially in cases of internal bleeding where symptoms may take time to appear. If the patient is unstable, perform a reassessment every 5 minutes. If stable, reassess every 15 minutes. Monitor for any changes in condition and adjust treatment as needed. Your interventions should include providing high-flow oxygen, controlling external bleeding, and treating for shock. Remember, do not delay transport just to complete an assessment. Getting the patient to definitive care is the priority. Communication and documentation are essential. Accurately estimate and report blood loss, the speed at which it occurred, and all treatment provided. Relay this information to hospital staff to ensure seamless continuity of care and appropriate intervention. Managing external bleeding is one of the most critical interventions an EMT can perform. First, always follow standard precautions by wearing gloves and eye protection. Ensure the patient has an open airway and is breathing adequately. High-flow oxygen may be necessary. Address any life-threatening bleeding as quickly as possible, as uncontrolled hemorrhage can rapidly lead to shock. There are several effective methods to control external bleeding. Direct pressure and elevation are the most common. Pressure dressings, splints, tourniquets, and hemostatic dressings are additional tools that can help manage severe bleeding. The key is to act quickly and decisively to prevent excessive blood loss. Direct pressure is the most effective way to control external bleeding. By applying firm, steady pressure with a sterile dressing, you can stop the flow of blood and allow the body's clotting mechanisms to take over. Hold uninterrupted pressure for at least 5 minutes. Remember, do not remove the dressing once applied, Doing so could disrupt clot formation. A pressure dressing provides continuous direct pressure over a wound, helping to control bleeding. Wrap a sterile, self-adhering roller bandage tightly around the wound, ensuring firm but not excessive pressure. If bleeding continues, apply additional dressings, but do not remove the initial one. If direct pressure and dressings are ineffective, a tourniquet may be needed. Hemostatic dressings are specially designed to promote clotting in severe wounds where direct pressure alone is insufficient. These dressings contain clot-enhancing substances and are particularly useful for deep wounds or injuries where tourniquets cannot be applied. Pack the wound tightly with the dressing and apply direct pressure to control bleeding. When bleeding from an extremity cannot be controlled by direct pressure, a tourniquet should be applied. Tourniquets work by completely stopping blood flow to the affected limb. Several commercial tourniquets are available, and they should be placed at least 2 inches above the bleeding site. Always note the time of application and tighten the tourniquet until bleeding stops. Junctional tourniquets are specialized devices used for life-threatening hemorrhages in areas where standard tourniquets cannot be applied, such as the groin or shoulder. These devices help compress major arteries and are essential in managing severe trauma. Proper training and application are critical for their effectiveness. Splints are not just for immobilizing fractures, they can also help control bleeding. Air splints, also known as pressure splints, apply uniform pressure to an entire extremity, reducing blood flow and stabilizing soft tissue injuries. However, they should never be used as a substitute for a tourniquet in cases of severe hemorrhage. Pelvic binders are a type of splint used specifically for patients with suspected unstable pelvic fractures. These devices help stabilize the pelvis and minimize internal bleeding. Pelvic fractures can cause significant blood loss, making prompt application of a pelvic binder crucial in pre-hospital care. Bleeding from the nose, ears, and mouth can result from various causes, including trauma, high blood pressure, sinus infections, or coagulation disorders. It is important to determine the underlying cause and provide appropriate care. A common emergency is epistaxis, or a nosebleed. While often minor, severe nosebleeds can lead to significant blood loss. Most cases can be controlled by pinching the nostrils together and having the patient lean forward to prevent blood from flowing into the airway. Bleeding from the nose or ears following a head injury may indicate a skull fracture. In these cases, do not attempt to stop the bleeding, as this could increase pressure in the skull. Instead, cover the area lightly with sterile gauze and monitor for signs of neurological deterioration. If cerebrospinal fluid is mixed with blood, it may create a distinctive halo sign on gauze, appearing as a light-colored ring around the blood. This is a serious indication of a skull fracture and requires immediate transport to the hospital. Internal bleeding often requires surgical intervention, but EMTs play a critical role in stabilizing the patient. Keep the patient calm, provide high-flow oxygen, maintain body temperature, and splint any suspected fractures. Rapid transport is essential for definitive care.